I'd like to introduce our speaker. Carly Wood is a licensed psychologist currently practicing at Norton Children's Medical Group Dixie. Dr. Wood graduated from her doctorate in psychology from Spalding University. She completed her pre-doctoral internship at Jackson Health System in Miami, Florida, with specific focus in adolescent dialectical behavior therapy. Dr. Wood went on to create a comprehensive dialectical behavior therapy program at Compass Counseling in Louisville and served as the program director for 3 years there. In addition to her work with Norton, Dr. Wood serves as an associate director of clinical training and adjunct clinical faculty for the School of Professional Psychology at Spalding University. And she is also the only one of 2 in the state that are board certified in dialectical behavior therapy. So welcome, Dr. Wood, and she will be talking to us today about identification and intervention with suicidal children and adolescents. So I'll turn it over to you, Dr. Wood.
Thank you. Good afternoon, everyone. As Dr. McDonald mentioned, I'm Dr. Carly Wood, and I'm really excited to be here with you all today presenting on this topic. It is a topic that I unfortunately speak about multiple times a day, every day in my clinical work, as well as in my teaching role. And it's a topic I'm really passionate about, so I'm excited to be here. And hopefully my big goal for the day is, if the only thing you walk away from today with is feeling a little more comfortable talking with patients about suicidality and risk, then I feel like we've met our overall objective for the day. Screen. There we go. Okay. All right. I saw the disclosures kind of rolling through an interim. There are no disclosures to discuss. That was a lovely introduction. The only thing that wasn't in there is I also am a clinical supervisor for a couple of practicum students, 2 here at Norton Children's Medical Group, but I also supervise at JCTC, which is a local community college in town. And along these lines, why am I here presenting this topic to you all? I already talked about how this is my passion, and it really is a consistent part of my daily job. And my overhead lights just went out. Sorry, 1 second. All right, they're on a motion sensor. Anyway, so it's an overall or a consistent part of my daily job, but I also am board certified in dialectical behavior therapy, which is an intervention created to treat suicidality and self-harm behaviors in adults that has also been adapted to teenagers and children. So the learning objectives for today, we want to describe the core components of child and adolescent suicidality and risk assessment. We're going to talk about what is suicidality, how do we do risk assessment, and what are the pieces of that. We're also going to review strategies for assessing suicidal risk in our child and adolescent patients, and review strategies for managing suicidality, mostly around how and when we elevate to a higher level of care. So I wanted to start today by talking a little bit about some of the legality around involuntary hospitalization, because if there is suicidality and we meet the check marks for plan and intent, then involuntary hospitalization or hospitalization in general would be the next pathway. So in Kentucky, this has not been updated since 1982, and it's pretty straightforward and clear about what has to happen for involuntary hospitalization. So you have to have someone who is a danger to themselves or others due to a mental illness. They have to be able to reasonably benefit from treatment, and hospitalization has to be the least restrictive mode of care. So if they could be safely maintained in a less restrictive mode of care in the state of Kentucky, you would not legally be able to involuntarily hospitalize anyone. Within Indiana, it's a little more vague and a little more open to interpretation. Indiana just states that any individual who is mentally ill and either dangerous or gravely disabled may be involuntarily detained or committed. And then it lists 3 main pathways in which you do that in the state of Indiana, which we're not going to go into details about. That is through emergency detention, which typically involves law enforcement, temporary commitment, which typically involves a mental health professional or a judge, and regular commitment. So I also just wanted to look at some statistics today, and I don't know if anyone else saw on the news last night or this morning. I know at dinner last night I got the update from Wave 3 about the Louisville suicide report. This is just some general state data, and it covers all ages. So what I really wanted to focus on was kind of what I've highlighted in the blue rectangle, which is that suicide is the second leading cause of death for ages 15 to 24 in the state of Kentucky. And obviously that includes some adults. And I know some pediatricians and mental health practitioners see folks through college age. So that would include some of that population, but it also includes our high school ages. So the 15 to 18. It's this 12th leading cause of death in Kentucky overall. So it's a much more frequent cause of death for that age group, 15 to 24. We also, in our public school systems, for those that participate in it, every 2 years, the public school systems have students complete a youth risk behavior survey, which looks at a lot of things, including substance use and sexual activity, and other risk behaviors. And it also looks at suicidality and suicidal ideation. So it's done every 2 years. So students, if you're a practitioner, you may have actually heard your patients talking about just completing it this year, or maybe you've gotten referrals from answers that they put on this survey. But our last data set's from 2023. So what this found in 2023 is that 15% of our high school students reported seriously considering suicide within a 12-month period. That is a very high number. What's higher is when we look at the middle school students who completed this survey, 17.4% of our Kentucky middle school students reported seriously considering themselves at some point in their lives. So it's possible that percentage is higher because it's not just looking at the last 12 months. And it is a higher percentage. Both feel really high for our middle school and high school population. So this is the state of Kentucky. Indiana, we see that the overall death by suicide rate for all ages has a higher prevalence in cause of death. In Indiana, it's 9th, and in Kentucky, it was 12th. And it's the third leading cause of death in Indiana for that age range of 15 to 24. Now, Indiana's Youth Risk Behavior Survey, it's the same survey. They only give theirs to their high school students. This percentage was alarming to me when I saw it. 25% of Indiana high school students reported having seriously considered suicide within a 12-month period. That is 1 in 4. If you see 8 patients in a day, and I know that's really conservative on the medical side, not so conservative on the mental health side. So if you see 8 patients in a day, this stat would mean you could assume 2 of those have seriously considered suicide in the last 12 months, which is why we need to be talking about this with every patient, every encounter, which we're going to talk a little bit more about later. So zooming out a little bit and looking at our nationwide data. So this came from the Children's Hospital Association, which includes about 50 children's emergency rooms that they collect data from. And so what they found was from 2016 to 2021, a 5-year period, suicide self-injury cases between the ages of 5 to 18 increased by 168.6%, which is also alarming. The reason 2021 is the last data point for them is because that number has not changed since 2021. So they have been collecting data each year and they're still seeing that same level of growth. So it has plateaued. It's not getting worse. It's also not getting better. However, one stat that jumped out at me was in 2024, suicide self-injury made up more than 1/3 of visits to children's hospitals emergency rooms. So 1 in 3 visits to an ER was due to a suicide self-injury. Now, it wasn't clear how they were classifying what suicide self-injury is. I'm going to talk a little bit on the next slide about my personal distinction and dialectical behavior therapy's distinction between the two. It is possible they were including non-suicidal self-injury in this, which may be why it's a higher number. They also have found that around 1 in 5 of all adolescent deaths are from suicide, and that it's the second leading cause of death in ages 10 to 14. This is nationwide. Kentucky and Indiana were different. And the third leading cause of death among ages 15 to 24. So overall, we have seen since 2016 an increase in suicide self-injury. It has plateaued as far as emergency department data goes, and it's still a really, really high percentage. So for the context of this presentation, you're going to hear me talk a lot about suicidal behaviors, death by suicide, and non-suicidal self-injury, which I tend to just call self-harm. And so my definitions and what my orientation dictates is maybe different than your organization or your theoretical orientation if you are a mental health clinician. So for today, suicidal behaviors is going to be any behavior that is engaged in with the intent to end life. While it doesn't have to be lethal, the intent to end your life was there. So a patient who took 10 Benadryl, not a lethal behavior, and if they took 10 Benadryl with the plan of ending their life, we would consider that a suicidal behavior, at least in the context of today's presentation. Self-harm, instead, is any behavior engaged in with the intent to cause pain. And in fact, it is not done with the intent to die. So if there is intent to die, we would not call that self-harm. We would call that a suicidal behavior. And how dialectical behavior therapy, and I look at self-harm within my practice, is that it is almost always a coping mechanism. Typically, children and adolescents engage in self-harming behaviors to stay alive. It is a way to not engage in a suicidal behavior. It is a coping resource, although I think we could all on this call today say that it is not the coping mechanism we would want our patients to use. It is a way for them to cope and stay alive. So a little bit on DBT's particular stance on suicidal behaviors, which is the framework I'm coming from today, and I come from with all of my patients, which is a much more validating and accepting view than I think some of the other orientations out there hold. We look at suicidal behavior, so any behavior engaged in with an intent to end life, as a learned way of coping with really intense emotional suffering when there are no other resources or coping mechanisms available to that patient. Whether it's because they couldn't use a skill, they didn't know a skill, their environment didn't support them in using a skill, they had or felt that they had no other options. This is their learned way of coping. DBT also views suicidal behaviors as a problem-solving behavior. Again, not the solution we ever want our patients to choose, and it does solve the problem of emotional suffering. And it does this by quite literally remediating negative emotional arousal and distress because the person is then deceased and therefore emotional arousal and distress have discontinued. Or it's a problem-solving behavior because it is the inevitable outcome of chronic, unregulated, out of control, unwanted emotions. And I know I for sure can point to some patients on my caseload that their life as it's currently lived is miserable, and that is also fatiguing. And so DBT and I view the suicidal behaviors as almost likely to occur. Again, our goal is to help them work towards a life worth living. We don't want our patients to engage in suicidal behavior. And it also, at times, we can see how the patient got there. So let's talk a little bit about risk assessment. And I think this is where everyone's anxiety goes up. And I feel in the room with providers or other clinicians or trainees of mine, this is where people get really uncomfortable and we almost start to get really robotic and methodic about how we go about this because there is a lot at stake. And so really what I want today is to dispel some of the fears and anxieties and unsureties about how we ask our patients about suicidality and a little bit of self-harm too. And really just gain a little more comfort. And as we know, that's going to come with practice. The more you do this, the easier it gets. And I hope today giving just some tips and tricks and a little bit of a flow sheet for how we do this might help. So when we're assessing for risk, what are we even talking about? So you'll hear a lot of times people say we're looking for plan, method, means, and intent. This is a tiny pet peeve of mine because this is a really out of order way of talking about this. And so instead I use, and you'll hear me say today, ideation. So those are our thoughts. Method, means, plan, and intent. So I'm going to reorder it. And I reorder it because it's a hierarchy. So you can't have intent without plan, means, and method. You can't have a plan without means and method, and you can't have means without a method. So they all build on one another. And so that's how we're going to go about our risk assessment, which we're going to talk more about in a few minutes. So that's what we're assessing. When are we assessing? Like you heard me say earlier, ideally every patient, every time. And I know that sounds like a lot, and maybe you don't have time for that. You have a really busy day, caseload, whatever it means. And if we ask the questions, we might be opening up the door for our patient to trust us to get help. And we wouldn't want to miss that opportunity if it presented itself. Now, I say every patient, every time. I am not asking about suicidal risk in every single therapy session. And it's because the caveat to this is, if I'm working with an 8-year-old with school anxiety, who's never had suicidal ideation and has never thought about it and has chronically denied it, I don't need to ask every time, right? So when relevant, when you know that that's not applicable for your patient, you don't have to ask every time. You should still, though, be asking them on at least a semi-regular basis, whether that's every 3 months, every 6 months. If you're a physician, once a year at their checkup. I know here at Norton, we give the PHQ-9 every 6 months for our 11-year-olds and older. And so it does have a question on that. So when I say every patient, every time, that's my little caveat there. We also want to make sure we're asking if there is a history of suicidal ideation or suicidal behaviors. And that typically is going to be every patient, every time. So the next kind of third of this equation is, how are we assessing? A lot of folks are using some kind of mental health screener. Norton uses the PHQ-9. There's also one called the CAMS, the SPS, which is the suicide probability scale, and then the Columbia. The VA primarily uses the Columbia. They all are getting at suicidality and risk, some a little more intentionally than others. The PHQ-9 is mostly assessing for depression symptoms and has one question that is vaguely asking about suicidality. So screeners are a great start. I also think we just need to have direct conversations with our patients. We need to be asking them, aside from putting a paper in their hand, we need to be asking them with our words, face to face, about their suicidality. If it's present, and if it has a history of being present, how we're monitoring that. So this is the PHQ-9 I was referring to. I'm sure most of you have seen it, but if you have not, it is mostly asking about depression symptoms. And then they have this final question down here that I highlighted, question 9, which asks, so overall, we're talking about the last 2 weeks. Have you been bothered by thoughts that you would be better off dead or hurting yourself in some way? I'm going to talk a little bit more about this in a minute. I have some qualms with that question, and it certainly cannot be the only way we ask our patients about their suicidality, which I will explain more in a minute. So how do we assess suicidal risk? We really just ask. Just say the words. And again, this is where we get uncomfortable. I think sometimes it feels like if I bring it up, I'm going to put the idea in their head, which is not true. We can demystify that today. If I don't know, then I don't have to do anything about it. Well, especially if you're a mental health clinician, I hope you asked, and I hope you documented that you asked, and I hope you documented the answers, because if not, there's some liability on your hands. And typically, we're just really uncomfortable around this topic. It feels like something taboo. Again, the more you do it, the less it'll feel that way. So when I say just ask, I don't mean hemming and hawing around the question. I don't mean sugarcoating. I honestly don't mean question 9 on the PHQ-9, which is honestly not asking about suicidality. That's asking potentially about self-harm. So my patients who self-harm, they're going to endorse a 1, 2, or 3 on that if they've self-harmed or thought about it in the last few days. And again, that's not suicidality. So the PHQ-9 is missing the mark on that question. So why do we not sugarcoat and beat around the bush? If we are uncomfortable and not being direct, our patients pick up on that. I can almost guarantee you, they are already feeling anxiety and shame around their suicidal thoughts or their suicidal behaviors. And if they pick up on the fact that we are uncomfortable, all we have done is provide an invalidating environment and increase their anxiety and shame, which one is harmful even if they go on to talk to us about it. But two, it might guarantee that they don't open up to us about it and they aren't honest. And then we do not have any opportunity to provide help and assistance. So I say try to avoid the question of, are you having thoughts about hurting or harming yourself? For the reason I just explained. It is really vague. It could be talking about self-harm. You ask that question, you're going to have to ask a follow-up question anyway. So what I mean with being direct and not sugarcoating, saying, have you had thoughts about killing yourself? Or have you had thoughts about ending your life? That's what we want to ask. Similarly, we'll talk about active and passive suicidality as well. You can also ask, have you had thoughts that you would be, things would be better off if you were dead? We don't want to say better off if you weren't here, because what does here mean? And again, we usually ask these more vague questions because we are uncomfortable and it feels too blunt to say, have you thought about killing yourself? And if you ask it in that way, it automatically is going to bring down the shame. It's going to normalize things a little bit for them, and they are much more likely to talk to you about what is going on. When we're asking, ideally, we want to do this without the caregiver in the room. Really, I think this is true of teenagers. It's also true of younger children. Now, if there is risk and we need to escalate to a higher level of care, we are always going to bring the caregiver back. And sometimes with the caregiver in the room or two caregivers in the room, it feels like maybe being ganged up on, right? A 2-on-1 or a 3-on-1, or maybe the parent doesn't know yet. And so the child's not going to tell you because now they're not only telling you, they're telling their caregiver. And that's a lot for a child who maybe was just walking in for their checkup to take on in that moment. So if you can meet with the patient without their caregiver in the room, that is ideal. I know sometimes that's not possible. Another way that we can assess suicidal risk is reviewing the screeners if your clinic utilizes them. If you use the PHQ-9 or the Columbia, going back through the answers that the patient endorsed. And again, if you can do this with the caregiver not in the room, that would also be ideal because it's possible that they sat somewhere else in the waiting room, filled it out where their caregiver couldn't see their answers. And that's the only reason why they were honest. So we want to try to do that without the caregiver in the room if possible. And then finally, if you have a behavioral health consultant in your clinic or a mental health professional, lean on them. And even if you don't, I know I'm speaking for all the mental health professionals as when I say this, I don't think any of us would be mad over a consultation, a de-identified consultation. I don't think anybody would be upset by that. If you're feeling unsure, or if you have a case where you don't know if you need to escalate to a higher level of care or not, it's always a good idea to consult. I know the providers here at my clinic bring me in every time when this comes up with patients, not to punt it to me, but to get a behavioral health consultant in there who our specialty should be risk assessment and assessing suicidality. I'll turn my light back on again. All right. So what are the parts of risk assessment? What are we actually doing when we're having this conversation with patients? So like you saw several slides ago, I add ideation to the front because there's no reason to ask any of these other questions if they're not having thoughts about suicide. So you want to ask about thoughts about ending their life or their life being ended, which is where our passive ideation comes in. So passive ideation are things like, if I didn't wake up, that would be okay. If a car hit me in the street, that would be all right. So they're not going to actively do anything to end their life. And if their life ended, they would be okay with that. That's our passive bucket. That is never going to require hospitalization because it's not active and it's not going to meet our other criteria. The other category we talk about with suicidal ideation is active. So they have thought about taking means themselves to end their life. That is going to tip off our next set of questions. So after we've determined that there is ideation, The next thing we want to know is method. And spoiler alert, anyone who has ever had a suicidal thought has a method. So we also won't necessarily hospitalize because we check that box. If someone has thought about actively ending their life, they have a method of choice, or they have several methods of choice that they would utilize. And you can bluntly ask, if you were going to end your life, how would you do it? Right? And they may tell you, they may not, right? We're still going to move on to our next question. Sometimes they'll say, I would overdose. Okay. That leads us to our means question. Do they have access to their method of choice? So if they say overdose, I need to start asking some questions about the medication in the house, access to other people's medication outside of the home, are parents and caregivers locking up medication? Do we have lethal medication, right? This is going to kick off a chain of questions. So through this risk assessment, we're not just asking 5 questions. We might be asking 25, 30, 40. We need to know enough information to meet the criteria for hospitalization if we think we're headed down that path. So if we have established ideation, method, and we're just going to use overdose for this example, and means, mom has Klonopin in the house, right? Now, and it's not locked up. Now we want to assess plan. So what is plan? Plan is the what, when, and where. Okay, so plan and intent, I think a lot of people think are synonymous. They are not. They are 2 different things. Plan is if I were going to do it, when, where, and how would I do it? So in this example, right, the method is to overdose. They have access. They're planning Thursday night after school to go home, sneak into mom's room, get the Klonopin, and take it. That's a plan. Okay. If we have checked that box, we need to ask about intent. And you can say, how likely are you to do that before I see you next time, right? If they're talking very actively about, I'm going to go home Thursday and take them, that's our intent. If they're saying, well, if I were going to do it, I could probably sneak into my mom's room and take it, that's plan, not intent. So we want to assess how likely they are to act on the plan. Whether the plan is lethal or not, that doesn't necessarily matter as far as checking these boxes. Also, those of us who are mental health professionals shouldn't be determining lethality based on questions anyway, because we don't know. We're not medical providers. And so, like I said, with each of these, you're going to ask a lot of follow-up questions. And the reason we do this is because sometimes just one more question lets us know, oh, we don't have any imminent risk, right? So they have method, they have means, they've thought about how and where they would do it, but they're like, oh, but I'm not actually going to do it. If we hadn't asked that question, we wouldn't know. Or they have method, plan, and intent, but they don't have any access to means, right? So that would be a different situation. Just one more question can make the difference. And the opposite of that too, one more question can make us feel confident in our decision to escalate to a higher level of care. So always, always, always come in with I'm going to steal this from Ted Lasso, a non-judgmentally curious mindset when we are talking with children and adolescents about suicidality. We want to be really curious, like investigators, without being harsh, without being judgmental, and also without sugarcoating, like we already talked about. Okay, so you have a patient in office. They have said that they have thought about actively ending their life. Now, what do you do? Everything we just talked about on the last slide. You're going to ask your questions. I don't follow a specific form or formula because every patient, this is different. And so following a formula might cause me to miss or overlook really important questions I need to ask the client. So we're going to assess our method, plan, means, plan, and intent. Do they check all 4 boxes? If they check all 4 boxes, that's going to be an automatic escalation to hospitalization. If they don't, we need to do some other strategies and interventions, which we will talk about. So we're assessing their level of intent. We also need to assess the supervision of their caregivers. So are caregivers available to provide necessary supervision for a child or adolescent who has suicidal thoughts? Are they willing to do that? So just because caregivers have the time doesn't mean they have the willingness or capacity to provide said supervision. So I know working with patients in the DBT clinic I was at before this, teens would be like, well, if you just send me home, then I can just be with my parent 24/7. And the parent's like, I can't and don't want to do that, nor should a parent have to, right? So availability and willingness, also commitment. So a parent may have availability, they may have willingness, but that doesn't mean they're going to agree to do it. You would have to have all three of those things to feel comfortable sending a child or adolescent home with a parent under caregiver supervision. But we also, with caregivers, need to be honestly talking to them about securing and or removing lethal means. And while we are talking to them, judging their willingness to do that. Some caregivers are really adamant that I'm not going to lock up all the medication because that's a hassle. And so now we unfortunately may have to escalate to a higher level of care because we don't have a caregiver who's going to help us make sure that the child remains safe. If parents are agreeable to this, we might have to do some problem solving with them. So Norton will provide gun locks. We may need to get them one. We may need to go pull up Amazon with them so they can buy a banker's box that locks to put medication or sharps in. We may need to problem solve, is there a friend or a family member you can call who can take these items from your home for a little while? It feels case managey. And when it comes to suicidal ideation and a potential child or adolescent who is having more active thoughts about ending their life, we have to step up and be a little more solution focused with these individuals. The final thing we're kind of globally assessing is if the patient feels they can keep themselves safe. So how is this different than assessing risk and intent? You may have a patient who says, today, I do not feel like I'm going to act on ending my life. And I also know that I'm tired. And if one more bad thing happens at school, I don't know that I can keep myself safe. That is enough to escalate our level of care because we have no control over the unpredictability of something else happening. So in our risk assessment, we also want to be creating a cope ahead plan. So what if you fail a test in math this week? Then how do you feel like you'd be able to keep yourself safe? We don't just necessarily want to stop at, I feel safe right now in this moment. We want to try to cope ahead, problem solve. And if they cannot tell you that they think they can keep themselves safe, then we need to take some action. So I'm going to talk about levels of risk. I want to give the caveat that this is my determination that I use personally in my personal practice. It may completely differ from your organization or your supervisor. So as always, follow your organization's rules around this, supervisor rules. These are my classifications that I have found to be helpful throughout my years of clinical work. So we're going to look at low, medium, high. I think that's kind of the easiest way to distinguish level of risk when it comes to suicidality. How I tend to classify this is low for me would be the patient is endorsing suicidal ideation, whether it's passive or active, but they are denying plan or intent, and they have no history of suicidal behaviors. I may have already talked to the caregivers about securing lethal means, whatever kind of that background happened. So what am I going to do for this level? I'm going to refer to therapy and or med management. We're not in a big rush. I don't want them to sit on a wait list for 6 months, and we don't need to be trying to call a colleague to get them in the next week or two. So that would be low risk for me. Medium risk is, again, they've endorsed suicidal ideation. They have no plan or intent right now. However, there is a history of engaging in suicidal behaviors. To me, I still am not going to hospitalize because I don't have plan or intent. I do want to get them started with mental health care as soon as possible, whether that's med management, therapy, or both. So I may reach out to therapy clinics in the area or have my admins call around to see who has availability, who can work this person in, or I personally might work them into the DBT clinic that we have here at this clinic. And then I think in medium situation, it's always helpful to follow up with the patient in 1 week. One, to know they know that there's a check-in coming in a week. And also so that you can make sure services got started. And if they didn't, you can help problem solve that for the family or the adolescent. High risk is where we have a little more acting that we have to do. So for me, high risk is you checked all 4 of my boxes, or they've told me that they don't think they can maintain their own safety. Those could be independent of each other, like we already talked about. And I will kind of directly say to clients, my patients in the DBT clinic know exactly what will get them hospitalized because I'm very clear about it in my informed consent. And so I might say to a patient, you've checked all 4 of my boxes. So now we need to talk about how we're going to get you safely to the hospital. And I'm that direct with it because almost always, not every time, a lot of times, a child or adolescent coming in and checking all 4 of your method, means, plan, or intent boxes knows they need help and wants help, but doesn't have the language to ask for it. And so they're instead going to endorse these things because they know that kicks off an action for you, the provider. So if this has happened, we do not want to leave that person in the room by themselves. Hopefully, if it's any child or adolescent, no matter your clinic, there is a caregiver there. And I know sometimes I have caregivers sneak out of the waiting room and go run errands. So we want someone in the room. We do not want to leave that person alone because then they have the opportunity to leave the clinic or the building without our knowledge. From there, we want to talk with the patient and the family. We want to validate that we can tell that things are really hard right now, and we are really proud that they were able to come in and communicate this to us. And also, we want to provide information on the process of hospitalization. 1, because it's going to more likely guarantee they go voluntarily, but 2, it's really disarming. For someone who's never been hospitalized, if they've only seen it on TikTok or movies or TV shows, it's terrifying. It is terrifying in real life. And walking through, taking 5-10 minutes to walk through the process with a patient can be incredibly helpful and validating for them, and can also ensure your rapport is maintained and that they come back and keep seeing you. Now, if you don't know what that looks like, I would encourage you to talk to a mental health professional, someone who works in an inpatient hospital, or just do your own research on what that process looks like in Kentucky, so that, or Indiana, or wherever you're located, so that you can give them some overview of what it looks like. You're not going to know every single minute of the process, and even just an overview is helpful. So at this point, we are referring to inpatient hospitalization. If the child or adolescent is willing to go, we can have the caregiver transport them, if and only if it is safe to do so. So if the parent pulls you out in the hall and says, they're agreeing to get in the car now, and I'm not sure that we don't get halfway there and they change their mind and open the door and get out of the car, then we don't want the caregiver to transport, right? We don't want to add any potential for any accidents or danger. Usually the caregiver is going to feel comfortable transporting, and we're also going to instruct them to go right now. We're not going to delay or add time in between that could lead to more accidents or changing of the mind. If the teen or child is unwilling, or the caregiver is denying to take them, both of which can happen, we can call EMS. You can ask for ambulance transportation instead of police car. They do not always follow that request. However, I'm always going to say it on the phone with 911. I'm going to say requesting ambulance transportation instead of law enforcement. Sometimes they listen, sometimes they don't. If it's a situation where the caregiver is denying, that is a CPS report for medical neglect. If you as a professional are saying that the child or adolescent has met criteria for hospitalization for suicidality and the parent is saying no, that is medical neglect. And so I will tell a parent, I see that you are, whatever the emotion is, frustrated, scared, busy, and if you don't take them, I have to report this to CPS for medical neglect. That typically changes the caregiver's mind, and they will transport them. And you need to get some kind of proof that they arrived. Now, in worst case scenario, which has happened and may happen to you, the patient, you're talking about hospitalization, they're sensing what's happening, they leave. Whether the parent takes them, it was a teen who drove themselves, whatever it is, that's an immediate call to 911. We do not chase patients ever, and so you're going to give your best description to law enforcement about what they were wearing, if you know what car they were in, and what direction they went. If they left on foot, if they went in a car. But we're not going to leave our clinic. We may go to the front door, but we're not going to leave our clinic and follow patients into the parking lot under any means. So that's how we're going to act if there's a high level of risk. Just for our own liability and protection, we are also going to document immediately as soon as that patient has left your office. Notes don't matter until they do. And if that note isn't in with exactly what was said and your rationale for hospitalizing and how you instructed the parent to get there, that could be a really big liability. So we want to document immediately, even if that means pushing your next patient back 3 minutes just to document. And finally, this may come 2 days or 2 weeks later. To discharge from a hospital, patients are required to have a follow-up with a medical provider who can continue the psychiatric medication, as well as a mental health clinician. And so whatever category you fall in of those two, making sure that when the hospital calls your office, you are open and willing to see that patient. Otherwise, they won't be allowed to discharge, or they're just going to call a different facility to schedule that appointment, and you might lose them as a patient. So that's kind of our train of thought for our high risk. Again, the patient just leaving is worst case scenario, and it does happen. And so I always think it's good to have a plan for worst case scenario, knowing that most of the time the caregiver is going to be willing to transport them and they're going to be able to get there safely. So just a couple of final thoughts before we move into questions here in a second. I've said this a couple of times today, and I really do mean it. Trainees often say to me, like, you just talk about suicidality and ask the questions like you're asking them about their friends at school. And it's because, one, I've done it a lot. And so the more you do it, the easier it gets. It's because I know how important it is to the patient to have someone talk to them about it, like it is just asking about their friends. Because anyone else in their world who knows about their suicidality is most likely interrogating them about it or punishing them for it. And so we have an opportunity to be a supportive, validating presence and reduce their anxiety, which, if they need hospitalization, is going to make it easier for us to get them there. Like I've also been talking about, don't be afraid to be direct. A teen may kind of like look at you funny when you're like, thought about killing yourself this week? And they're also a lot more likely to answer you honestly. Teens especially do really well with irreverence and directness, and they know when you are not being genuine and they can sniff it out. And that's just going to increase the anxiety. So it's better to be direct. And then you can document that you directly asked the question, which is also just good on the legal side. Ask a lot of clarifying questions. Don't think, oh, I'm asking too much, I'm just being curious or nosy. When it comes to suicidality, if you have a question that's nagging in your head, ask the patient that question, or the family if it's around making sure the home environment is safe. And ultimately, trust your clinical gut. If you do this long enough, you'll get a sense for when patients are really at risk, whether they're saying it or not. If you have that feeling, don't be afraid to err on the side of caution. We are a no-fault state. You can refer to the hospitalization, even if you feel like there's a risk and the patient isn't being honest with you. I typically don't do that just because I want to make sure that the boxes are checked for hospitalization. And there has been a time or two where I have said, and I'll say out loud to the patient, I know you're answering the questions this way, and I feel really uncomfortable letting you go home today. And so we will send to the hospital. It's okay to trust your clinical gut. The hospital is another step in the process. And so they are going to assess again. And then they can send the patient home if they don't feel hospitalization is necessary. So if you feel like the patient needs a higher level of care, you've consulted, you've asked questions, it is always okay to send and refer on just to be safe. I'm going to skip the questions slide for just 1 second. So I did put some local and national resources on the slides as well. So these are Louisville local, if you're in the Louisville area, some crisis hotlines, some places where you can do walk-in appointments, and then some national hotlines and crisis numbers as well that we can give to our patients to utilize if they need them. Or that we can have on a handout or whatever method we need to get patients access. Okay. Did leave some time for questions. I wasn't sure I was going to. So, any questions?
All right, thanks, Carly. So what's driving the prevalence of the younger age being, suicidal?
I think it's a lot of things. I think one part of it is that it may not be as much of an increase as we think it is. People are just talking about it more. Um, Stop sharing my screen as well. I think that is part of it. I think social media plays a role. I feel like a real older millennial saying that. It does. I think, my TikTok listens to me do therapy all day. I get on TikTok when I get home and it's full of mental health TikToks, some helpful and some really unhelpful. I think it for teenagers at times in certain schools especially has become trendy to be mentally ill. And if your friends are self-harming and you have a bad day, you might try it. But again, I think a big piece of it is people have always been self-harming and people have always had suicidal thoughts. They just weren't talking about it. And they certainly weren't coming into their medical doctor and disclosing it.
Okay. How long has the Kentucky Youth Risk Behavior Survey been given?
That I don't know, but I remember being a high schooler back in 2000, early 2000s, taking it.
Hmm.
And it's every 2 years, and every state has their own data collection. But I believe the survey is the same questions for every state.
Okay. And then when does that start? At what age?
Depends on the state. Some states started in 6th grade, some states started in 9th grade.
Okay. And is 988 a good resource for pediatrics?
It is. I think anything is helpful, and 988 can also redirect to other appropriate service lines if they are not.
Okay. And then your DBT, are you doing straight DBT at Dixie?
1 day a week, we
One
are
day. Okay.
DBT. Only for Dixie patients. I have to give that caveat.
Okay. And then so in your experience, what how many kids are you seeing that with thoughts about suicide, prevalence wise?
So I'll break it up between my clinical work and any integrateds I get pulled into. Clinically, 1 to 2 a day. The integrateds my physicians are pulling me on, I would say 1 to 2 a week.
Okay. Okay. And then with the increase in virtual visits, at what level of assessment would you recommend in-person visits only?
That's a tricky one, and even I go back and forth. If it's possible for them to come in person if there's suicidal ideation, I'm always going to request that, especially if there's active suicidality, just because we have a little more control in the room when they're here. If they are unable to come in person, I think some therapy with a greater risk is better than no therapy at all. And so I would not ever tell a person that I wouldn't see them just because they couldn't come into the clinic. That's a hard line though, and that's why every virtual session we need to be asking where they are and what the address is and what a good contact phone number for them is. Because if you have to call EMS and you don't have the address, you can't do anything. Don't just trust what Epic tells you is their home address.
Good points. All right. All right. That's all of our questions. Thank you.